evening to one and all present here on this special occasion of Women's Day. I, Diksha Gambhir from Medisage E-Learning Private Limited, a platform where medical minds unite to elevate knowledge and transform patient care, warmly welcomes you to our third Med Talk on Her Health, Her Power, a guide to women's wellness. So let's celebrate the strength, resilience, and well-being of women worldwide with our expert, Dr. Ritu Santwani, a renowned obstetrician and gynecologist, infertility specialist, and sexologist. She holds prestigious qualifications MBBS, MD, FICOG, FIAOG, Art Singapore, and is the founder and CEO of 360 Degree Healthcare Studio, NUHS Singapore. Recognized among the top 50 influential doctors on social media, she is also the co founder of MAM and board member of SWWC. So, Dr. Santwani, we would love to hear your insights on this important topic. To start with some questions under the banner sexual and reproductive health challenges. So, ma'am, once you introduce the audience, we'll be moving on to the questions.
Yeah. So first of all, thank you, Diksha, for such lovely introduction. And thank you, Medisage, and the team behind the screen. I am able to see Akash and Karan. Big thanks to both of you also for providing the platform and running this smooth program. So really, this is a nice initiative. Actually, myself is also very fond of the knowledge sharing. और वो बोलते हैं ना दीक्षा उस पर मिल गई है जो मुझसे भी ज्यादा हमेशा फॉलो अप लेने पे लगी रहती है सो actually for due to time constraints it's a little problematic for me to give the every day or in a every week time. So anyhow, today on the eve of the International Women's Day, me and Diksha have decided that today we will going to discuss some important women health issues. So
Yes.
we will take some questions, and meanwhile, if the audience who has joined live, warm welcome to all of you. If there are any questions related to that, irrespective of the topic, you are free to write in the chat box, and whatever is the possibility, Diksha will take and ask me, and I will try to give the answers. Before that, Diksha, I have received, once I posted yesterday for this program on my social media, I have received two queries from the doctors. One doctor has from Aligarh. His name is Dr. Singh. Huh? So he has written, ma'am, I am really waiting as your series was earlier coming on different sexual health issues. Please start that. Another query I have got from Dr. Ojha, that is from Dr. Shalini Ojha. She is from Bihar, Ranchi. So she has written that she want to discuss something more about the pregnancy related complications. So soon we will plan some program and definitely we will start the series. Yeah, over to
Sure,
you,
ma'am.
Diksha. Yeah.
Sure, ma'am. We'll take this knowledge initiative ahead and we will answer the queries of all our audiences. So,
Yeah.
moving on to the questions under the banner of sexual and reproductive health challenges. The first question is: how can a gynecologist effectively address sexual dysfunction and reproductive health concerns in women hesitant to discuss the issues?
Yeah. So, Diksha, basically, I am also a gynecologist. So, once I came in the contact of the so many sexual health experts, then I had gone further to do the sexual health diploma. Then I had done that. So, what happens? Being a female, so आपके पास जो बहुत सारे patients आते हैं, this I am giving a message for all the young doctors who are joining. See, in Maharashtra, that is okay. There are a lot of male gynecologists. But if you go towards the north side, there is a more trend in the gynec is only the female gynecologist. Hardly आपको कोई एक या दो आपको male gynecologist मिल जाए. Otherwise, if you go towards the Saurashtra side, in the Gujarat side, there are so many male gynecologists. So once you start the practice of the gynec, lot of patients will come and ask you that, ma'am, we are having this problem. We are not getting pregnant. First question, they are saying that problem they are saying that we are not getting pregnant, ma'am. Then you have to take the history very deeply. Huh? Bata? Then you have to ask them. So, you have to ask them that why she is not getting pregnant. Then in that detailed history, being a gynecologist, you have to take all in the further discussion that whether there is a problem in the sexual intercourse, whether there is a problem in the desire. Some patients are coming to us that who are not getting the desire. So there is a loss, or they are earlier having the desire, but now they are not getting the desire. So there is loss of libido, or there is vaginismus, means those who are having a uh, fear of the insertion, or sometimes they are having a earlier good sexual uh, later on they are having some problems in the sexual content. So being a gynecologist, once you are proceeding towards a sexual health consultant, of course you have to ask all these minute things to the patient separately also. And one, there should be two conversation, means proper history and proper counseling is the key if you are going in the field of the sexual health medicine. So you want I should elaborate more? Huh.
No, ma'am. We will, sum it up in all the
Huh.
questions that are coming ahead. So, moving
Huh.
on to the next question, what are the latest advancements in diagnosing and managing female sexual pain disorders such as vulvodynia and dyspareunia?
Yes. So earlier what happens ki this was only, we are diagnosing only by the history, or once the patient is saying ki that she is not allowing even the fingering to the partner. Now these days there are a lot of tests are available, especially if the patient is telling to you that she is having the severe dyspareunia. So there is what we give them, that is dilators can be used as for the diagnosis, also for the treatment also. There are the different kind of the vaginal dilators are available, which will help in diagnosing us that up to what degree she is having the dyspareunia and or vaginismus. So we can diagnose by that also. And these days some patients are coming to us telling us, ma'am, आप खाली sonography कर लो, sonography में आपको पता लग जाएगा. So that is not like that, unless and until if you are having some severe adhesions down, or you are having some other problems, endometriosis like that, then only endometriosis से जब grade 3 and grade 4 होता है, तब patient को severe dyspareunia होता है. So basically इसमें सबसे important यही है कि proper checking होना चाहिए. And yes, some tests we are doing, as I told you, yes, we can use some dilators.
Okay, great, ma'am. So, moving on to the next question, what are the challenges in integrating psychological support into routine obstetric care and how can we overcome them? I'm sorry, I think there's a wrong question I asked. That was a part of the next banner.
Yeah.
So, how do we balance contraceptive counseling with addressing fertility concerns in women with PCOS and endometriosis?
Okay. See, for the PCOS, as we know, for both these conditions, PCOS and endometriosis. In PCOS, the patients who are coming to us usually with the irregular cycles. And as you directly asked the question about this contraceptive usage and contraceptive counseling, so we have to explain the patient. Yes, of course, first we will tell them about the lifestyle changes, some dietary changes. Along with that, if still there the hormone regulation is very high, if hormones are not in balance, hormone irregulation is very high, means serum testosterone is very high, and LH-FSH ratio is highly disturbed. In that cases, of course, we have to go for the contraceptive pills. In that, we have to explain the patient that what we are starting, the low dose estrogen and low dose progesterone pills that are not going to as harmful as the pills was available earlier. Because what happened these days, Diksha, whatever the thing you write, first and foremost, the patient will go outside and Google it and then read. Ma'am, इसमें तो इतना सारा estrogen है. So how can I take? इससे मेरा weight बढ़ जाएगा, या मेरे headache होने लगेगा, या मेरे hair fall होने लगेगा. So you have to explain the patient that yes, of course, the contraceptives what we are giving for correcting the hormone regulation is the very low dose of estrogen and low dose of progesterone. One thing. In some cases, we are giving some non-hormonal contraceptives also. So like Civista is available, lot of other things are available, means Musmifene, these kind of things are available. Coming to the endometriosis, in endometriosis, yes, we are giving sometimes hormonal injections also. Once in 3 months or every month, we are giving the injection.
Okay.
So before giving to the patient, you have to explain them properly. Yes, we have tried all these things, but these things are not giving you the result. Then we are going for the hormone. And once you are giving the hormones, please be very careful, especially once we are using estrogen and progesterone. As we know, Diksha, ki lot of youngsters who are coming to us with this PCOS and this endometriosis are chain smokers. Sorry to say, but so many young girls are coming to me, जिनका smoking का बहुत high है. So we have to be very conscious once we are giving the hormone estrogen, that estrogen again will be is not good in the patients who are chain smokers, or the patients who are having associated some thyroid issues, or some patients I am seeing these days, the obese patients with a history of varicose veins, yeah, or the history of deep vein thrombosis. So these 2 3 points we have to keep in our mind. But otherwise, if you do the proper counseling and proper treatment, if you explain them that why you are starting the contraceptive, or why are you giving the injections in the patients of endometriosis, then of course the patient is usually ready to take. Before that, I want to add, as आपने PCOS और endometriosis पूछा, इसके अलावा हमारे पास फाइब्रॉइड का भी बहुत पेशेंट आता है, these three. So in fibroid also, we are giving the products like this dinogestrone, we are giving Dinogest, we are giving for the fibroids. Earlier, the ulipristal acetate was used. Now, these days, Algolix is the new molecule has come, that has been also used. But all the pros and cons, what with this drugs can happen, like irregular menses, scanty menses, or spotting, or in some patients, if the dose is more, totally amenorrhea can be happen. So we have to explain all these things in the detail. Then I think it's easy to tell. And proper follow-up is the key in the patients once we are starting this, any of the hormone preparation.
Okay, great, ma'am. So we are moving to the next banner, which is postpartum depression and maternal mental health. So under this, doctor, the first question would be, what
Yes.
early screening tools and interventions can gynecologists use to identify and manage postpartum depression more effectively? Which is, I think, a common problem amongst
Please
women.
again come. Some messages come.
Yeah.
Huh.
So, doctor, I would repeat the question. What early screening tools and interventions can gynecologists use to identify and manage postpartum depression more effectively? As this
Huh.
has become very common amongst the women.
Yes. So postpartum depression के लिए ऐसे tools तो मैं नहीं बोल सकती, पर history जो होता है, sorry my phone, mobile, its laptop is getting totally different. So इसके लिए जो सबसे important होता है, as we have commonly seen these days related to patients of postpartum depression. Earlier क्या होता था कि what we are seeing in the postpartum depression patients, कि as they are expecting the male baby, and if the female baby is born, there is lot of family pressure, and the
Yeah.
female keeps on crying of pressure from the in-laws or from the husband, that why it's happened, and then suddenly the lady goes into the depression. पर अभी आजकल भी बहुत recently बताती हूँ कि 3 हफ्ते पहले ही a patient of mine, a primary patient, infertility treated patient, delivered a healthy baby, healthy boy, healthy male baby. That too is the normal delivery, not even the C-section. So after we discharged her on the third day, and after 12 days, her husband called me, ma'am, that she all the times is holding the baby and crying and crying. So, and she's not in the Pune now, and she has gone to her hometown. So I told her, please show to some gynaec there, otherwise you can connect her with me. So she was not ready to talk to me on the phone. So the patient who was so close to me, she has given me such a nice testimonial. I had treated her infertility and she conceived the baby. Then I told her husband, आप कैसे भी करके उसको लेकर आओ. So when she came to in my chamber, she was very much hesitant. She was not cheerful and happy as she was earlier to be. And she came along with the baby and along with her mom and husband. So I told that the baby and mom can sit outside, and you and your husband can come inside my chamber.
Hmm.
So that at that time only, when she inside, she was not able to answer any of my question. I asked her that what's the problem, that why you are getting so much depressed now. The male baby is there, everyone is so happy, and your nothing is problem, no pain is with you. So in the
Hmm.
cases of the postpartum depression, so proper history taking is very important. Why she was depressed, once we have taken
Hmm.
a detailed history, she feels a lot of loneliness, and she is finding that her importance is reduced. And because husband is also very much worried about the baby, all the time asking about the baby, and her parents, she has gone to her mom's place, and there also everyone is caring and asking about the baby. No one is asking about her. That actually it seems little rare, that of course every mom likes that her baby to be pampered, पर कभी कभी ऐसा होता है पेशेंट को. अभी यूजुअली जो हमने देखा है कि अगर फीमेल बेबी होता है तो ज्यादातर लोग होता है कि डिप्रेशन में जाते हैं कि हाँ
Right.
मेल बेबी का था, ऑल द टाइम्स इन लॉस. पर ये एंड व्हाट हैपेंड, दिस लेडी was earlier to use take fludex, means a drug, a sertraline and fluoxetine antidepressant she was
Hmm.
used to take, which जो हमने प्रेगनेंसी में उसका बंद कर दिया था.
Hmm.
And plus from last round 12 weeks, means prior to delivery, she had gone to her mom place. So what happened कि अब प्रेगनेंसी के बाद जब लेडी लैक्टेशन पीरियड में होती है, तो लैक्टेशन पीरियड में
Right.
वंस द हार्मोन प्रोलैक्टिन इज इंक्रीज, सो दिस
Right.
हार्मोन प्रोलैक्टिन is again decreases the estrogen level, which again causes the vaginal dryness. So
Hmm.
husband on the conversation told me that once they are trying also, she is not ready for the sexual intercourse, and she is not allowing even the foreplay also. And
Hmm.
so she feels all the time that she is lonely. और तो proper history taking in these kind of patients is very very important.
Hmm.
Besides that, as कभी कभी ऐसा होता है, जैसे मैंने बोला कि the lady was taking the sertraline and fluoxetine from since long time,
Hmm.
means long, around 3 years she was, then once she become pregnant, that time we taper. So sudden कभी कभी ऐसा होता है कि gradual withdrawal, ये तो ग्रेजुअल विड्रॉल हुआ कि अगर उसको 9 मंथ्स
Right.
पे हमने धीरे धीरे विड्रॉ किया, और समटाइम्स some things can be triggered. So in the cases of the postpartum depression also, the proper history taking and proper counseling, and we use the term TLC, the tender loving care is very, very important. Along with that, we will give some medications also. We start with the some medicines that all will help. And usually
Right.
problem solve ho jata hai, but needs a detailed 2-3 sittings with the patient.
Right.
Yeah.
So
Huh.
thank you, ma'am, for the detailed explanation with an example. So, the moving on to the next question, how does maternal mental health impact breastfeeding outcomes, and what strategies can be employed to support affected mothers? I think it is what very much related to the question that
Hmm.
was above.
Yeah. So yes, sometimes once the mother goes in depression, she is not ready to feed the baby also. She want to sit alone in one room, in the dark room, needs not to be disturbed by anyone. So in that case, of course, मैं बोल रही हूँ ना, इसमें postpartum depression में medicine से ज्यादा counseling ही काम करती है. So
Hmm.
we have to tell the patient that you
TLC.
have to feed the baby, and
Hmm.
even though if she is not ready to feed, but someone from the family, either the husband, mom or mom-in-law, can, once the baby is crying, of course बच्चा तो हर 2-3 घंटे में रोएगा ही जब उसको भूख
Right.
लगेगी. So that time they have to take the baby and put her near nipple. So once the baby starts sucking, that of course will start more milk production, because एक tickling reflex बोलते हैं जिससे कि milk का production भी ज्यादा होता है. और पेशेंट का, जब पेशेंट बेबी को फीड करा रही है एंड हस्बैंड इज अलोंग विथ हर, सो एज वी नो द ऑक्सीटोसिन इज नोन एज अ curdling hormone that will start secreting more. Besides, as in patient diet also, we will tell to do some changes, to include some chocolate, to include some fruits like pomegranate, that all will increase the serotonin as a mood elevator. So usually हम pregnancy के time पर और the breastfeeding time पर we usually try to avoid some kind of drugs, as all the drugs will pass directly into the
Yeah.
milk. So, but if
Yeah.
the patient is very much anxious, very much tense, of course, we will start some medicines with very, very small dose.
Hmm.
with explaining all the pros and cons. So as you told, in that case आपको मदर को अच्छे से एक्सप्लेन करना है कि बेबी उसकी फर्स्ट प्रायोरिटी है, और अगर वो
Right.
बेबी को फीड नहीं कराएगी तो फिर बेबी का पेट कैसे भरेगा, देन बेबी विल ऑल्सो. सो आई थिंक वंस वी डू द प्रॉपर काउंसलिंग बहुत सारा प्रॉब्लम सॉल्व हो जाता है, बहुत सारा हो जाता है दीक्षा. हाँ. हाँ.
Right. So
हाँ.
thank you, ma'am. Now moving on to the next question. What are the challenges in integrating psychological support into routine obstetric care, and how can we overcome them?
Overcome them, so we can say, my dear,
Hmm.
support, as you asked in the earlier questions also we have discussed, the first and foremost, or किसी का support हो ना हो, support from the husband is the must. So either the baby was born is the male or female baby, but the support from the husband is must. Second, the support from the in-laws, because now she is staying more with the in-laws compared to the her parents. So support from the in-laws is also very important. Third, see,
Right.
there's a large impact of the social media also. I must include this point.
Yes.
Some have taken the social media in the good progressive manner, while others are having a negative impact by the social media. क्योंकि अभी
Right.
क्या है, आजकल बहुत सारे लोग सोशल मीडिया में आफ्टर द बर्थ ऑफ द बेबी or after or for anything they put all the news declaring on the Facebook or Insta. So some are feeling happy, yes, my all the things are going on good, and some may feel depressed by चलो उनको लड़का हो गया मुझे तो लड़की हुई, and the baby
Right.
is constantly having all the good things, my baby is not proper growth, my pregnancy weight was little less. So
Comparisons are there.
या comparisons are there. So
Mhm.
अभी सबके साथ comparison करके कोई मतलब नहीं होता, that we have to
Right.
explain the patient. So everyone and each one is born with their own destiny. तो अब हर चीज के लिए हम सबको compare नहीं कर सकते. So
Exactly.
God has decided for everyone the some unique thing. But yes, as you asked, the proper history taking and the proper care from the especially from the husband is very very important. So whenever the patient of PPD, we use the term postpartum depression, PPD, is approaches to us, the first and foremost, once we give the appointment to the patient, the presence of the husband will be the must in that setting.
Okay. Great.
Yeah.
So moving on to the next question under the banner obesity and metabolic syndrome in women. So as there was World Obesity Day on 4th of March, this will be very relevant to the Women's International Women Day that is coming tomorrow. So how
Hmm.
can we improve early detection and prevention of metabolic syndrome in women of reproductive age, particularly those with PCOS or gestational diabetes?
Okay. So what happened, Diksha? See, this all things are mutually correlated. If, if the weight is more, the chances of PCOS are high. If the PCOS is there, then of course the patient is usually the patients are obese. And in the obese patients, the chances of the gestational diabetes, or I can say type 2 diabetes, is also high. So now how to you are saying, if the body weight, the BMI index, anybody can calculate, everybody these days is aware that if their BMI is more, usually we tell to keep the BMI between 18 to 23. If the BMI is more, then of course the chances of complication are more. So in this, we tell the patient, if patient is coming to us in our OPD, leave this PCOS. If the patient is coming to us in our OPD, for her menstrual cycles are normal and no problem. But once we are checking, her weight is 85, 85 or 90 kg, her weight is, and husband is 100 plus. So in that case, first and foremost, once you take the detailed history from that, these patients, these couples, so they will tell he first and foremost, there is a, I'm starting with the sexual history. In the males, if the weight is too much, there is a little problems in the erection and ejaculation. When coming to the females, first problem it come, there is a little of lack of libido or loss of libido. They will tell you कि suddenly उनका sexual में interest कम हो गया है. Second, because of this high BMI, as you told, asked me about the metabolic syndrome. So
Yes.
all the parameters, usually the cholesterol is high, HDL is less, LDL is high. So,
Mhm.
and besides that, these patients are having a more chances of the fatty liver,
Yes.
gallbladder carcinoma, gallbladder stones. These all chances are the high. And
Mm.
um, so in these patients, first and foremost, we say if your weight is high, then the chances of the ovulation, as the lady has to ovulate properly to become pregnant, so the chances of ovulation per month is also reduced. So we will tell them, yes, you have to reduce your weight at least minimum 5% of the weight. Then at least the hormone जो imbalance हुआ है estrogen progesterone का and testosterone hormone usually goes high in these patients. तो अगर आपका hormone regulation ठीक होगा तो definitely आपका ovulation ठीक होगा. Then the chances of conceiving will also become high. And
Yeah.
coming, आपने इसके आगे भी कुछ पूछा था. Sorry, I missed PCOS and one more thing you
This is
asked
your
me, na?
gestational diabetes के बारे
हाँ,
में.
gestational diabetes, yes. So, yes, of course, we have seen in a lot of patients, obese patients, the chances of gestational diabetes are high. Besides that, in metabolic syndrome, as you asked, if the PCOS we are not going to treat, if our endometrium is not shedding every month, in that patients later on chances of endometrial carcinoma will be high. Similarly, for the gestational diabetes, as we know, in that patients and in the obese patients, अगर pregnant हो भी गए, तो फिर बेबी का कई बार दो तरह से प्रेजेंटेशन होता है, या तो मदर के अंदर इतना फैट है, या तो उसका
Mm.
बेबी का ग्रोथ प्रॉपर नहीं होता, जिसको हम आईयूआर, वी यूज द टर्म आईयूआर, इंट्रायूट्राइन ग्रोथ रिटार्डेशन, बेबी का ग्रोथ कम होता है. और इन
Okay.
सम पेशेंट्स हैव फाइंड द इफ द ओबेसिटी एंड this diabetes both are there, so some patients are having lot of liquor in the tummy, that the term what we use is the polyhydramnios. तो कम
Yeah.
होता है तो उसको हम बोलते हैं ओलिगोहाइड्रोमनियोस, ज्यादा होता है तो पॉलीहाइड्रोमनियोस. तो इन ओबीस डायबिटिक पेशेंट्स जो एमनियोटिक फ्लूइड होता है वो बहुत ज्यादा हो जाता है, द टर्म यूजेस पॉलीहाइड्रोमनियोस, जिसकी वजह से पेशेंट में गो इन द प्री टर्म लेबर, chances of sudden intrauterine death is also high, and chances of the cord entanglement in the baby is also high. So these are the some points what we have to remember. Yeah.
Great, ma'am. That was very informative. So, moving on to the next question,
Sure.
what are the most effective lifestyle and medical interventions for managing obesity in pregnancy without compromising fetal health?
Hmm. See, once the lady is pregnant, so first and foremost, she is always have the pressure that she has to eat for the two, or if she is having twin pregnancy, she has to eat for the three. तो क्योंकि हमारे यहाँ क्या होता है, सारे लोग उसको जब
Correct.
प्रेग्नेंट होती है लेडी, तो जितने लोग मिलते हैं, जो भी मिलेगा वो हर हर एक जना तो डॉक्टर बन के उसको बताता है, तुम प्रेग्नेंट हो, तुम ये खा लो भाई, इससे बच्चे की ग्रोथ अच्छी हो जाएगी. हाँ, या
Right.
तुम आप तुम्हें ज्यादा खाना है, तुम्हें कोई फास्टिंग नहीं करनी है, नहीं तो
ज्यादा
बच्चे
घी
की
खाना
ग्रोथ
है.
नहीं होगी. So I'm being an infertility specialist. Mostly of the patients what are delivering either the twins or triplets. So patient को बार बार हम समझाते हैं कि अगर आप अभी इतना ज्यादा खाओगे, अगर इतना ज्यादा वेट गेन होगा, तो लेटर ऑन आपको उतना ही वेट शेड ऑफ करने
Lose
के लिए
period.
परेशानी होगी.
Right.
So she has to take around 300 calories more at the time of the pregnancy, and when she is lactating, the 500 calories more are needed compared to the normal. Then coming to the uh, yeah. So we tell the patients, yeah, diet and effective lifestyle management. Yes, even though she is pregnant, she is supposed to walk some. ऐसा नहीं है कि pregnancy है, pregnancy is a joyous energy. This is not like that she has to lie down all the time. So we
Right.
tell the patient that minimum 40
Active.
minutes walk 40 minutes walk she has to do, either a 20 minutes to sitting or whatever is comfortable for her. If she can't go outside, at least at her home, post lunch, dinner, she can walk little bit. And in her diet, yes, she has to take the good rich food, but not like that she has to take all the fatty substances. She can increase more green leafy vegetables, more fresh fruits, that all are helpful for the her
Right.
and for baby also. इसी में मैं दो तीन चीजें आपको एक बताती हूँ. Patient approach to me along with her mother-in-law. Earlier she used to come. हाँ, मॉम इन लॉ टेल मी, मैम आपने इसको बोला था कोकोनट वाटर लेने के लिए, बट आई हैव हर्ड अ मदर इन लॉ टोल्ड मी दैट शी वाज अ रिटायर्ड प्रिंसिपल फ्रॉम सम स्कूल, but I have heard in my village that if my this daughter-in-law is going to take the coconut water, the baby head will be enlarged. and so she won't be able to deliver the normal baby. So
Okay.
this is totally a myth. ऐसा कुछ भी नहीं होता है, बिकॉज गर्मियों का टाइम होता है तो पेशेंट को डिहाइड्रेशन के चांसेस ज्यादा होते हैं, क्योंकि तो हम यूजुअली बोलते हैं पेशेंट को लेने के लिए, तो अगर आप हफ्ते में 1 या 2 बार ले रहे हैं तो इससे कोई भी प्रॉब्लम नहीं होता. Among
Right.
this diet only, the other, what the common queries usually the patients are having, that they can't take the papaya. They are having a feeling if they take the papaya, so
They feel vomit.
yeah, baby will come out and abortion will happen. So that is also a myth. 2-3 pieces of ripe papaya she can take. Only what we say कि आपको कच्चा पपीता नहीं खाना है, unripe
I
papaya
think,
she
ma'am, seeds abortive होते हैं ना?
हाँ
The
हाँ
seeds
यस,
are abortive.
सीड सपोर्टेड. ड्राई पपाया में पपायन होता है, और पर उतना नहीं होता, मतलब जो रॉ पपाया, मतलब रॉ पपाया का सैलेड खाते हैं, आपने सुना होगा बहुत लोग,
Right.
तो
सब्जी
वो
भी
हम
खाते
मना करते हैं खाने. हाँ,
हैं.
वो मना करते हैं. बाकी राई पपाया कोई खाएगा तो कितना खाएगा, 1 बाउल खाएगा, कोई इतना बड़ा भर के तो नहीं खाएगा ना प्रेगनेंसी में वैसे भी.
Right.
So then, so usually we have to explain all the things. What I suggest na, Diksha, you plan one session in that way you ask me the questions related to myths and facts in the pregnancy. So that will
Right.
be, I think, will clarify a lot of things related to diet, related to exercise. That will be an interesting topic also, because lot
Yes,
of
exactly.
queries everyone having in before we wind up. I want to add one more example. Today morning only, the one mother-in-law asked me, ma'am, my daughter-in-law is every day taking one banana. How she can deliver a baby? I told them what happened with the banana. She told me, you know, banana is sticky now. The baby will get stick in the uterus. Baby won't come out. Then doctors will get the chance to do the cesarean section. Huh? So that's where doctors are, ma'am, I have never heard about this, that the banana will cause the sticking of the baby in the uterus. So these all are the common myths. I
Right.
purposefully told here because your Medisage platform is seen by a lot of patients also. So this will clarify their doubts also.
Right.
Huh.
So, ma'am, now we are moving to the last question of the session.
Diksha, now can we wind up, my dear? I'm getting constantly call from the center, please. Huh? I
Okay,
will do
okay, no
another.
problem.
Huh?
Yeah. Okay, ma'am. So,
Huh?
so we'll close this session, and
Huh?
I would like to give my heartfelt gratitude to you, ma'am, for your exceptional session on Her Health, Her Power, a guide to women's wellness. It was an enriching discussion filled with knowledge and insights. So we hope our audience found it both engaging and informative. So looking forward for more insightful webinars on women health in future as well. So thank you, and wishing everyone a very happy Women's Day. Thank you so much for joining in, ma'am.
Thank you. Thank you, my dear. Bye-bye. Thanks
Bye,
to
ma'am.
everyone from Medisage team. Bye.
Thank you, ma'am. Bye bye.